Yeah, so good morning, everyone. Let's start with our main stem. Thank you very much once again joining on the Sunday. So we can start. Meanwhile, people join in 10 minutes, 5-10 minutes. So I'm Dr. Munjal Pandya. I'm a medical oncologist, hematologist, and a bone marrow transplant fellow. So I'll take you to the good journey of excellent MCQ, which were recently asked in the exam of various DHA, HAD, and MOH. As I told you, I'm a hemato-oncologist and have a fair experience of treating the patients close to 20 years and thousands of doctors coached so far. Dr. Aarti is in our team. She is a consultant pediatrician. Dr. Maddy is internal medicine. Dr. Ankit is a gastroenterologist. Dr. Shikha based at Dubai. She is a consultant gynecologist. These all are taking lectures regularly. This is also our team, and recently three doctors joined, Dr. Mariam, Sonal, and Islam. So they are all expert in their own field, so they are going to deliver you the lectures for all various subjects. This is recently updated. A new book will going to launch in the May end or June, the latest version. So this is also latest, but it was 6 months back now. We are updating the book, so probably in next couple of months you'll gonna get this latest, absolutely updated books with new questions, answers, explanations, and pictures. We have excellent offers for mock test. Those who want to join, they can contact Pallavi. This is the number of me and Pallavi. So Pallavi will guide you about the various packages, which is like around 60 to 70% discounted. Probably you can take advantage of month end, so she will guide you. We also give the guidance for data flow and we'll do the exclusive data flow. We have excellent mock test uploaded on our website. So every lectures, every time I'll request and shout, you must do the mock test. Probably you are not doing the mock test overall in general, but you try to do the maximum mock test and try to check your score. How is your score? Do the self assessment. Where are you standing before going the exam? I think that would be the great things, right? Which will give you the confidence before really going for the exam, right? So this is extremely important. We have all subject wise module answers, explanations, everything on the website. All right. And last but not the least, as I told you, there are a lot of we launched the EMREE last year, and we are recently probably flying next month and to Dubai. So those who are in Dubai, they can see me. They can get personal one-to-one guidance as well for anything, either DHA or EMREE. So we'll guide you for that as well. And this is various discounted packages and rates. So I strongly recommend this one for all the doctors. Those who are like not in the coaching, it is worth to do it. This is 40 hours coaching. It one of the best, which is supposed to be 900 to 1000. It's just 350. So you later on you can inquire about it. So Palla will gonna guide you bit in detail. And this all things you're gonna get it in all things. There are lots of things you get in the combo offer A to Z. Hard copy book, ebook, subscription, WhatsApp subscription, mod test, video library, live test, mobile application, recorded videos, and lot more. And last but not the least, this is our mobile application on Android and iPhone. So those who are right now not using the mobile application, you can download from the Apple Store, right, for the mobile application and Android as well. And there are hundreds of excellent mock tests and video, right, which you must go through it, and that really help you to crack the exam for sure, right? So there is no doubt about it. And last but not the least slide before we jump to our session. So this is extremely I prepared generally by my experience why people cannot crack the exam. It's very interesting, right? I mean, don't take it personally, but these are few reason I come across over period of time, right? I do a lot of research on this, and I just make some little list, right? Why people cannot crack the exam. So these are the few things by which probably it may be relate to you or not, but it's important. On authentic study material, lack of study material. This is the biggest reason. Na? We don't have the proper study material. So what we do, we usually rely on online materials, free materials, some ala files, blue files. There are a lot of files available on the Facebook, Insta, and maybe other social medias, right? With no answer, no reference, no pictures, ECGs, X-rays, smear, details, explanation. right? And not practicing regular mock tests. This is not, nothing is available on the social media. They have just probably the question, and how much authentic, I don't know. I don't want to criticize, but in general, this is my experience. So people usually comes to me, we or my team with second attempt, third attempt, last attempt, and they are bit little desperate. So I don't want you to be a desperate in last attempt. Better you prepare from first attempt very well. Consider your first attempt is the last attempt, then your preparation would be more sincere, right? So this is one of the biggest thing. You must have good study, authentic study material. Second thing is no mentor. Why is this no mentor? Right, who can guide you properly from day one for exam preparation, syllabus, pattern, how to prepare, what to prepare, what not to prepare. So these all are very very important, right? So you should have, and without mentor you probably go into your own comfort zone, right? Like, oh, I have a lot of time, I will do it. What is urgent? Nothing urgent, right? So these are all various things, right? It comes in the mind. So you probably go into the comfort zone, and end of the day you won't prepare well, right? Third thing is a lack of time management. I've seen many doctors who have no time management end of the day, and they left with some unanswered question in the exam, and result into that they may end up with some failure, right? Lack of timetable, every day's timetable. Probably this is not a part of MCQ or my mock test, but if you concentrate on it, I think it is probably more important than the MCQ, what I'm trying to do it with you now in next 60, 70, 80 minutes, right? So lack of timetable. We are doing random preparation, haphazard, without planning. So without planning, I don't think it's gonna be a worth for you, right? Because you need to know na, where you want to go, how much you want to do today. So every day morning when you wake up, you should have some time, some kind of timetable. What you gonna do today? So that is extremely important. Taking premature exam date is again a biggest culprit, right? I've seen many doctors, they are especially in the first attempt, right? They say, oh, 1 month is enough, right? I don't doubt on your intelligence part, but take a reasonable time, right, for you to prepare, because it is not difficult exam, same way it is not very lollipop exam. So you need a little time. I'm giving you general 2 months of time for those doctors who are full time. So those who are full time preparing for exam, nothing else, no job, no hospital, nothing, 1.5 to 2 months is enough. And those are doing with the job, 3 months to 4 months time is enough, right? So you take some time for you to prepare, because it's not that easy to spend every day 4 hours. You do and try it for 3 days. Next 3 days, right? Genuinely, you try to do 4 hours preparation, sincere 4 hours of preparation, and see whether you can able to do it or not. If you can able to do it, take a date of 2 months. If not, then take a 3 months. So don't take a premature exam date, right? You are brilliant, you are intelligent, but prepare well. Now that these exams are little tougher than before. The 5, 10 years before, I was seeing the questions, and now it's huge difference. I'm doing this for more than 12 years now. So I've seen the whole pattern in last 1 decade, how they are changing the MCQ pattern, not in touch with the clinic academy, right? So there are many doctors, those who are not doing job, especially the female, they become they have small kids, they cannot go to the clinic, they touch from the academics and the books. For them, I strongly recommend join live coaching. That would be really important for uh, concept clarity. Being in the comfort zone, this is the biggest culprit, comfort zone. So without leaving the comfort zone, you cannot get success. So leave your comfort zone, try to push yourself a bit hard and fast, as what we do in CPR, push hard, push fast. I think probably this sentence applicable here. So get out of the comfort zone, remove your excusitis is a disease. By me, excuses, stop giving the excuses to yourself or your family. Try to be more sincere on your preparation, your dream, your this beautiful life ahead, right? And without cracking the exam, nothing works, right? Overconfident or underconfident. So you don't need to be overconfident. Oh, I'll crack it. Don't worry. I knows everything. This is overconfident. Underconfident. Oh, I knows nothing. So prepare well. Basically, prepare well, right? So I already told comfort zone and lack of dream. When somebody doesn't have a dream of good quality of life for themselves or for family, then they cannot crack the exam. So this is general list, don't take it otherwise. This is what I felt I should add this one slide. So those you are related with any of 1 to 10 reasons, try to concentrate on that. And let's start with the main stem and let's discuss. The first question in front of your screen. A 63-year-old postmenopausal woman is referred for gynecological clinic by her primary care physician for evaluation of genital pruritus of 1 month duration. She has a remote history of HPV, human papilloma virus. She denies changes in the vaginal discharge or bleeding. She also denies constitutional symptoms or weight loss. On examination, she is in no apparent distress and her heart rate is 70 per minute, blood pressure is 100 over 58, respiratory rate is 10 per minute. Genital examination reveals an ulcerative white lesion approximately 1 centimeter in diameter on her labia majora. What is the most appropriate next step in the management? Obtain a biopsy of the lesion, prescribe estrogen cream to be applied to area, treat with acyclovir, treat with cryotherapy, treat with fluconazole, treat with metronidazole. So just take your time. Those who are new joining me first time, let me remind you once again. I want to know three things in any MCQ. As you know, this is my favorite triad of MCQs where you gonna know what is the diagnosis. So we did not know what is the diagnosis of this scenario. So those who is interacting, first tell me what is the diagnosis. Second thing is how you gonna investigate. That is the second question asked to yourself. And third question asked to yourself is a treatment. So here they are asking about the management. So management is probably what would you do the next best step, most appropriate step, right? So probably you need to know the diagnosis or possible diagnosis. You have a 15 seconds for every question, so you must manage your time. I mean, even longer than this scenario may come in the exam, so don't get surprised, right? Because every time there is no one liner questions, believe me. So you need to do practice. Yes, anyone else wants to interact? What could be the likely diagnosis of this patient? Anyone? Bonnie, now
It could
you
be
can open up your
carcinoma,
mouth.
as
Sorry.
she has a history of human papilloma virus. I think yeah, it's, most probably carcinoma.
Okay, so
Okay.
human papilloma virus is culprit for this condition, right? So what
Yes.
could be the diagnosis? What do you think? What this patient could be? One, two, three differential diagnosis.
Actually, I'm not aware of the type, but I think most probably this is a carcinoma. If you can give me the options, I can say them. I can choose.
So this
But
is
I
the
forgot
option. This
already.
patient comes to your
Yes.
OPD doctor. So
Yes.
what do you think that that this patient is suffering from? So this patient, what is the primary problem? She is a postmenopausal,
Yes.
63 elderly lady. She has a genital pruritus for 1 month durations, right? She has a
Yes.
remote means long back history of HPV virus infections. There is no other discharge, no bleeding, nothing, otherwise fine, no other constitutional symptoms, not in distress, vitally stable. But on examination, she has a genital examination reveals ulcerative white lesion approximately 1 centimeter in diameter on labia majora. So ulcer on the labia majora in 63 years of female who has a pruritus. What you don't want to miss in this patient?
Walner carcinoma.
Excellent. So carcinoma basically. So carcinoma you don't want to miss carcinoma or CA, carcinoma shortly called known as CA, or it's a vulva,
Yes.
right? It's on the vulva. So vulvar CA, it's likely diagnosis. So vulvar CA. So when you are suspecting this patient has a possible vulvar CA, what you gonna do from A to F in this patients? What would be the first priority for you to do for this patient? Are you going to start any treatment or you confirm the diagnosis and then jump on the treatment? What you gonna do for this patient?
Confirm the treatment. Biopsy most probably.
Okay, fine. So you confirm before starting the treatment. So how you gonna confirm for this patient? You are suspecting vulvar CA. So how you gonna confirm for this patient?
Bone biopsy.
Biopsy, basically simple. So obtain a biopsy of the lesion, right? So this could be the
Yes, sir.
answer. So biopsy of this lesion is the most important thing, right? Now tell me the second thing, where this all treatment will works, where you are going to subscribe estrogen cream, right, to a
Yes.
patient, right,
Atopic
where
vagina.
you gonna, so which condition you will going to prescribe estrogen cream to the vulvar areas? You need to
Atopic
know that as well, na?
Atopic vaginitis.
The answer for this is correct. Absolutely. Those who has given the A answer, it's done. But now more five questions I have for you. This that means we are closing almost 10 questions in one MCQ. So which is the give me the name of the condition where you prescribe estrogen cream to vulvar area? Anyone?
atrophic in
Like
cases of
atopic vaginitis.
yes.
Excellent, excellent. Atrophic vaginitis. Atrophic vaginitis is a condition in which you can gonna apply this. So if they ask the
Intestinal.
questions of atrophic vaginitis, what is the treatment? Then this is the treatment. You must
Is
know it.
estrogen.
When will you use the acyclovir in this genital area?
Is herpes
Herpes simplex.
infection.
Herpes
Herpes.
simplex virus. So if you are suspecting some vesicle, some fever or herpetic things, right? Then you're gonna use this acyclovir. When you gonna treat this, treat with cryotherapy. Which condition in which you use the cryotherapy? Anyone?
In any there, if there are any polyp or like or something.
What?
Molluscum
Polyp,
What's
What? Genital
polyp?
what, sir?
polyp genital
Wonderful,
polyp.
wonderful.
polyp,
Fluconazole,
It's a,
Fungal
if there any
viral,
infection,
fungal
fungal
infection,
infections.
basically fungal infection. Can you name the fungal infection in genital area?
Yeah.
trichomonas vaginae,
Sorry.
trichomonas vaginasis,
So trichomonas.
no trichomonas, no.
trichomonasis,
Candidiasis,
trichomonosis,
Candidiasis. Right.
candidiasis.
So somebody told me trichomonasis. So there are questions. Trichomoniasis. What is the treatment of choice? These all are the exam questions.
bacterial
What is
vaginosis,
the drug of choice for trichomoniasis?
The bacterium,
This one?
yeah,
Metron.
Sorry.
metronidazole.
Metronidazole?
Okay. So metronidazole is used in trichomoniasis, right?
yes,
Yes,
yes, sir.
Wonderful. So you need to know each and everything. Our job is not just to exclude the answer. Our job is not just to give the answer, but you do the practice. Why this not? Why this not? Why this not? Why this not? And why this not? Once you try to develop the practice of excluding the other things, you are a master of MCQ. Believe me, I solved thousands and thousands of MCQs, teaching, learning, coaching, right? This is the best way of learning. So now onwards, when you give any answer A, B, C, D, try to remove why these are not the answer. Is that clear to you? Yes or no?
yes, sir.
Yes, sir.
Yes or no? Great,
Yes, sir.
wonderful. So now the answer is A. This is a common presentation of vulvar carcinoma, typically present in 60 to 70s. And the most common presenting symptoms or complaint is vulvar pruritus. That is what in the scenario. Everything is there in the scenario, right? So if you listen the and read the scenario well, you don't need to see the options even. You can make some impression. Previous HPV infection is a major risk factor for development of vulval carcinoma. So HPV. Recently, I had given a big talk on the human papilloma virus in my community, right? So HPV. So HPV is the major culprit. So HPV is a human papilloma virus vaccine. Just for your kind knowledge, it can be given in men as well as it can be given in women. This vaccine ideally recommendation is 9 to 26, but you can give up to 45. So 9 to 45. So you can give it to your children, right? So 9 years to 24, 9 years to 45 years. Just for your knowledge, this all are exam question. 9 to 14 years of age, two vaccine dose, right? On day zero and after 6 months, 6 months, two dose. 9 to 14 years, two dose of HPV vaccine, and 15 to 45 years of age, three dose, zero, two, and six. Here, zero and 6 directly. So those your daughter is like say for 9 to 14, you go and give the HPV vaccine, right? If she is a 9 to 14, give two dose, 0 years and 6 months. I mean 0 months. Zero means the day on which you give. So say for example, somebody has given today, 27th of the 4th of 25, and if your child is between 0 to 14, after 6 months means 24, 7, 10, 25 after 6 months. 4 to 10, 4 plus 10 is 6 months. So after 6 months, you get, right? So here you give on April, here you give June, and here you give in the 10th, right? So this is the month, right? So this is 3 dose. So somebody, right, even if you are between 15 to 45 years of female, you must take the HPV vaccine, right? It is highly recommended, especially before the sexually active. But still, if you are a risk factor, you have a diabetes, you have a this sexual transmitted diseases, or or if someone has is a high risk factor, even though they can take at up to 45 years, there are 3 dose. This is 2 dose. This is exam questions recently asked, so I'm discussing it here. So men, it helps in the anorectal cancer, genital warts, it gives the things, and anorectal cancer as well, anorectal cancer. Woman, HPV, obviously vulvar cancer, right? Vulvar cancer, cervical cancer, anorectal cancer. Which strains is most important? 6, 11, 16, 18. Exam question. Which HPV strains are the most common? Amongst the most common is 16 and 18,
617.
right? This four strain, the vaccine is available, called as a quadrivalent. Quadri means four, quadrivalent. Same way, nanovalent vaccine is also available. Nanovalent. So this four strain plus extra additional five strains are this HPV. Just for your knowledge, they have almost 200 different strains of HPV virus. Amongst that, this four out of 200, this four is responsible for 70% of the cervical cancer, right? And those who have a cervical cancer, 95% people have HPV virus. What does it mean? HPV has a direct correlation with the cervical cancer. So if you put the HPV vaccine, you are safe from all the problems related with the HPV. What are the problem related with HPV in men and women? These are the problem. So HPV vaccine is highly recommended in all females from 9 to 45. 9 to 45. That's it. This is my experience, especially those who are living in Asian countries, right? 9 to 45, it is recommended. You must give the vaccine to you, yourself, and your kids as well. So HPV is extremely important. Are you getting me? Yes or no? At least tell me yes or no. So I
Yes,
know
sir.
that you
Sir,
are
I
with
have a
me.
question.
Yes, please. Ask me the question.
Sir, you said that in the age group of 9 to 14s there are 2 doses, but if
Yes.
this person goes to the age above 14, then if she or need to get another booster dose.
No, 3 dose. If somebody is more than 15, no booster dose is there. If your
Okay,
kid is 9 to 14, give at 0 after 6 months, second dose. This is 2 dose vaccine. If
okay.
your yourself or your kid is 15 to 45, 3 dose. 0 means on the day of vaccine, 2 months after first dose, 6 months after. So
Yes,
0 and
I can
6 will be the
understand, but
same.
I'm supposed to tell you that if this 14 years old child becomes 30 years, then will she need any other
No,
doses?
no, 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 no.
No.
If you
Okay,
have given the correct 2 doses, then no booster dose is required.
okay, okay. Thank
Is that clear or no?
you. Yes, I'm clear.
No booster dose is required, doctor. In 9 to 14, if you deliver the and somehow somebody is asking me few days back in my camp of cervical cancer, I vaccinated 160 female. Last Sunday, I'll share the videos. It was in local media as well. It was a big program. So I'll share. So, right. So say for example, 0, 2 and 6, you have 3 doses or 0 or 6. Somehow you cannot able to take 6 months dose by any reason. You are out of country, whatever the reason, so recommendation is that whether you have 2 dose or 3 dose, take all these 2 dose or 3 dose within 12 months. It is also okay. Is that clear?
Yes.
Yes or no?
Sir, can I ask a question?
Yes, please.
Sir, I have inquired in the market. There are two companies which provide Gardasil and Cervavax. One
Correct.
says
Yes.
that it is only for age, I think, less
20.
than 14 something.
Sorry,
Kindly,
what's your question? Sorry, I'm not hearing you, sir. Can you repeat it, please? I think your
So
mic is mute.
there are two vaccines available right now, maybe more, but I don't have knowledge. This Gardasil and Cervarix.
Yes,
But
that's
this
correct.
Cervarix is not for females who are at the age group of 15, 45 years. Is it correct?
It is given, sir. It is given. It is given up to 45 years of age. It is recommended. I was just cross-checking with the CDC. CDC is a this US infectious disease website. It is recommended up to 45 years of age. Up to 49 to 26 globally accepted. There is no discussion. But recent data says, and we had given recently as well, and it is written in the literature. So if you wish, I can share that literature with you in the group, or share me the message on this number. I will share you the official literature which mention, right? This is my direct number, Dr. Munjal, right? So I will share more details on things. But for the time being, for the exam point of view, right? If you want to remember this can be given very safely to the female, right? So HPV vaccine. So so you write down the homework. I give the homework as well. Cervical cancer. Read complete chapter of cervical cancer and vaccine. This is second thing. And third thing is a logistic related with the pap smear. These three things are absolutely asked in the exam. Every exam you have either a question on pap smear or on the vaccine or on the cervical cancer, how they present, how you diagnose, what the suspected things. So I try my level best to cover up a lot of things under one thing. So that's it. So this is what the thing is, HPV. So you can feel free to post me after the class. Any questions? I would be glad and happy to give you the all literature, authentic material. WhatsApp me on this, right? So this is what the thing is. So this
So
is
are the
something.
both the vaccines are the both the vaccines same or there is some difference?
There are same vaccine. Gardasil is international brand. Sarvavac is Serum Institute by Pune, right? There are two main vaccines available in the market. As I told you, quadrivalent and nanovalent. Quadrivalent contains 4, 6, 11, 16, 18, and nanovalent contains 9. Obviously, nanovalent has little more coverage, but at least you take a quadrivalent vaccine for you or yourself or your kids. It is enough because majority of the cervical cancer and HPV related manifestation is occur because of these four common main strains. So quadrivalent is also a good vaccine. If you can afford, cost in India is roughly 4,000 rupees for nanovalent and 2,000 rupees for quadrivalent. So if you can afford nanovalent, wonderful, best, you can give quadrivalent. Otherwise, at least give the quadrivalent to you, yourself and your kids. By and large, the vaccine is same, sir. It's just a different manufacture. Rather, India is exporting to hundreds of countries globally our vaccine serum, and we also distributed millions of vaccine of COVID-19 globally, including European countries, Western world, and Canada. Right. So that's it. So answer B was topical estrogen, as I told you, atrophic vaginitis, acyclovirus for herpes simplex virus, right? And then cryotherapy is used for condylomata acuminata and anogenital warts. Candida albicans, fluconazole can be used, and bacterial vaginosis or this things, metronidazole is used, right? So that's it. So let's jump to the next question. So answer for first question is vulvar carcinoma. Do the biopsy and rest of the other logistic you need to also know for the better clarity. Second questions in front of your screen. 32-year-old sportsman who recently attended a wild game feed banquet consumed summer sausage made from the bear meat. Her complaints of abdominal discomfort, diarrhea, and muscle tenderness. What's the most likely diagnosis is? Trichinosis, salmonellosis, giardiasis, ascariasis, shigellosis. Can anyone tell all of above can be caused by which organism? That is also important
Yes.
and exam
Sir,
question.
it's geodiasis.
Option A.
So you post your answer in the chat box. So we will discuss. We have a chat box. So you can post answer in the chat box. Yes, Lalita, what's your comment?
Sir, it is caused by trichinosis, trichinella species.
What's your answer, doctor?
Option A.
Option A. Okay, so what point favor in the trichinosis? Why it is not salmonellosis? Why it is not giardiasis? Why it is not shigellosis? Why it is trichinosis?
Uh,
Anyone, open for all. This is my question. Okay, fine. A is the answer. Then I'm asking why not B? What is different in B from A? How you differentiate? Sir, if this is the present, then it is a B. You got my question. Why?
Due to improperly cooked.
Sorry?
Um, this is diarrhea, sir. If it was dysentery, then giardiasis or
The giardiasis.
salmonellus.
Amebosis, giardiasis.
Shigellosis would have been there.
So we have all
Because
the answer, I
shigellosis, there
think.
is no blood dysentery.
So those who are
I think we
interacting,
all know the other options well. That's why we
no, I
excluded the
understand.
options actually.
Yeah. So I take it granted as answer A
I
because
think in
everybody
trichinosis
somebody is
there is
telling me
muscle
B
pain.
is.
All the things are not causing any muscle pain.
So what is the answer? I want the
I
answer.
think
That's
A.
it.
I think
Option
A.
A, sir.
Trichinosis.
Trichinosis. Now tell me. Okay, fine. Fair enough. Now tell me all five things caused by which organism. Trichinosis caused by which organism? Chalo, one by one. You
Trichinella
must know.
spiralis.
Spiral larva.
Trichinella spiralis.
Spiral.
Okay, salmonellosis is.
Salmonella enteritidis and Bangori.
Okay, giardiasis,
Lamblia giardiasis.
Ascaria,
Ascaria lumbricoides.
shigellosis,
There are four serotypes of Shigella. Shigella Sonei, Boydii, dysentery, and flexneri.
wonderful. So now let's jump to the how it looks like.
Hmm.
That was the a little different picture, but I will share with you later on. So this is a trichinosis. This is a parasite infections caused by roundworm, right?
Okay,
And
for
yeah, the treatment is albendazole or mebendazole can be effective in eliminating the intestinal worm and larvae. Trichinosis is as I told you, salmonellosis is salmonella, right? Bacteria called salmonella. Giardiasis is called as a Giardia duodenale. You just little know the things, right? We don't need to mug up, right? Here we are for the knowledge sharing. Otherwise, everything is in the book, but we need to open up our mind. Ascariasis is Ascaria lumbricoides, as doctor told, and Shigellosis is gram-negative bacteria Shigella species. So, what your homework today is to know the treatment of each and everything. Take the picture of this slide, treatment of this. 100% question will come. So if you want to secure your score, go and do some exercise or homework. This is second homework. First homework is cervical carcinoma, pap smear and vaccine. This is the second homework. Related with this, I just missed that picture in the first atrophic, vulvar carcinoma. So this is how it looks like. I probably had a little late slide, but just I don't want to miss this slide. Bacterial vaginosis, mainly Gardnerella vaginalis. This is looks like a gray or milky discharge. This picture is very difficult to get it in the book. I got it from another journal for you to understand. So you can take a picture or later on you can see on our YouTube channel, right? So bacterial vaginosis, and how is the order? Fishy order and positive amine test, VIV test. This all are the exam question. This all are the exam question. The pH is elevated and you can see the clue cells. So these are the 4 5 things you need to know specific for bacterial vaginosis caused by this looks like this, right? It is milky discharge. Why it is milky discharge, right? Near cervix. Positive amine test, fishy order. Second is a trichomonasis. Trichomona vaginalis is the culprit. Strawberry cervix is a red like a strawberry, right? Yellow green frothy discharge. Yellow green. Yellow. It is yellow greenish discharge. You can see the color as well. You can differentiate the color. Here milky white. Here is a yellow green, right? Frothy. It's like a frothy sputum or like frothy discharge. False smelling. This is a fishy order, like you feel that you are in a fish market, like that. This is fishy, this is false smelling, and this is flagellated protozoa. This is organism. pH is more than 4.5. And yeast, right? Candida albicans, it's a thick white curd-like discharge. So white curd-like, yeah. Milk is a vaginosis, curd is a yeast or candida. So thick white curd-like discharge, cottage cheese appearance, right? And is a pseudo hyphae. This is the things. So just remember, this is extremely important slide for you guys to know how you differ one from another. So extremely important slide, 100% not get in the routine books. I got it from journal. So take a picture or keep in mind, right? That's it. So second question is done. Third question's little tricky but important. Check all your knowledge today in various departments. This is pulmonology. Visually, we try to avoid this ABG wala things. So in moderate to severe asthmatic patient, you will find all of the following except means not found. You will not get the clue in this exam, but I'm giving you. In moderate to severe asthmatic patient, you find all of the following except means something which you cannot find. PaO2 is less than 60, PaCO2 is more than 60, normal range is given in the bracket. HCO3 is 32, 22, 26 is normal. IV hydrocortisone will relieve the symptoms after few hours. pH is 7.30. Take your time, try to understand the questions and answer. Yes, Kaushika, any comment on this? Yes, Kaushika. Would you like to make any comment? It's important question. Very frequently asked questions as well. So this is the third homework is to read. Go and read the asthma. How you diagnose asthma? What is
I
FE?
think E.
You post your answer, doctor. Who is A? Tell me.
I think
Post
so.
your answer in the
Reasons
chat box so I can understand who has given the answer. So we can interact. Yes, Bonnie, any comment?
Yes, I think it is respiratory acidosis we may get, but in cases of total
So
pH, I think
one
it's
minute.
E. I
Okay, so
think E
respiratory.
will not
Okay,
get
fine. So
because
no problem.
this would cause respiratory acidosis, but it will not
Fair
cause
enough.
any
So in severe asthmatic patient, what is the problem? Respiratory acidosis, right?
yes, yes,
Okay, fine. Respiratory acidosis. So how do you? There are two words, respiratory and acidosis, right? So
yes,
acidosis means pH is how much? Normal pH is understand the things rather than mugging up, understand
yes,
the things. 7.35 to 45 is a normal. So in
yes.
acidosis, pH is 7.35 less or more than 7.45.
Then
7.35 less. It will be less in cases of respiratory
Less
acidosis.
than 7.335 means
here is
7.30.
mentioning
So it's a correct,
Yes.
7.35,
na?
so
It's
it's
a
more than
respiratory acidosis. They are
Hmm.
asking except means which is not there. In respiratory acidosis, acidosis
Will
is
not
there.
go,
You got my
but
point, yes or no?
Yes, sir.
Bonnie, you got my point, yes or no?
they are not mentioning that this is respiratory acidosis. If this is a respiratory acidosis, then it is fine. But in
Severe
metabolic
asthmatic patient,
total
we are not
pH, we'll
thinking of.
get alkalosis. We'll find. I
So
think
you think that pH is not less than 7.35 in respiratory acidosis?
yes, respiratory acidosis is fine. Yes, I'll
Yeah,
get
so
this.
yeah, because you told me this looks like a respiratory acidosis. So
Yes,
respiratory acidosis pH is less than 7.35. So this is correct. Means answer of your E option is wrong. Because you can
Wrong.
see it, na? They are saying severe asthmatic patient, you will find all. So I can find this. I can find this as well. Hypoxia. I can find this PaCO2 is more. Respiratory means, right, 35 to 45 is normal. If it is more than 45, it is acidosis. So CO2 increase in acidosis, right? So this is also correct. Hypoxia would be also there. This is also correct. IV hydrocortisone will relieve symptoms after few hours, not immediately. That is also
but
correct.
the question, I think this is a tricky question. If this is
Yeah, this is
you are
tricky
mentioning
question.
all the respiratory system, then it's fine. But in cases of metabolic state, we'll find pH a little bit higher. There will be metabolic alkalosis, I think.
I
Then the
understand, but
bicarbonate 32 will be the correct answer.
so whenever you have a condition, you need to see the what is the primary thing happening. right? Compensatory is the secondary thing, doctor. So in severe asthmatic patient, if I can ask you, what is the primary pathology, metabolic or respiratory?
Respiratory, sir.
Respiratory, sir.
Respiratory. Now, second question. In severe asthma, respiratory acidosis or alkalosis?
Respiratory
This is due to
Acidosis.
bronchoconstriction.
Acidosis. So this thing is clear. To compensate that, there is a metabolic alkalosis. Metabolic alkalosis. That is compensatory mechanism, right? And in metabolic alkalosis, what happens to HCO3? HCO3 increase or decrease?
Increased.
When there is a alkalosis, HCO3 increase or decrease?
Increase.
Increase.
In metabolic alkalosis, HCO3 has a two things. HCO3 normal is 22 to 26. Understand first the basic thing. If HCO3 is low, what is the condition? If HCO3 is high, what is the condition? If it is less than 22, what happens? If it is more than 26, what happens? Forget about everything. Acidosis or alkalosis. Low HCO3 is what and high HCO3 is what?
Low HCO3
Until
is
and unless you
acidosis
understand the
and
basic, you can't answer.
Low HCO3
DG.
is acidosis
source and high is
and high
alkalosis.
is alkalosis.
Right. So metabolic alkalosis, what is supposed to be the HCO3 result when there is you have asthma patient, severe asthmatic patient who develop already respiratory acidosis, right? To compensate that, again he developed the metabolic alkalosis. So what you expect in the ABG for HCO3? Increase, normal or decrease? That is my question.
Increase.
Increase.
It will increase, sir, but metabolic alkalosis is done by kidneys, so it will take lot of time for bicarbonates to increase. In acute or severe condition, it's not possible for metabolic alkalosis to happen so early.
Fair enough.
Compensated.
Fair enough. Fair enough. Fair enough. Fair enough. Fair enough. So now let's little understand the ABG. Simple. Forget about everything now. Important normal value in ABG. This is all important normal value in ABG. We must know it, right? Little bit of these things we must know it. So what is the normal pH? First of all, any ABG classes, ABG interpretation, your first job is in ABG. So whenever you are interpreting ABG, first your job is to look at the pH. That is the first job. In pH, there are two steps: acidosis or alkalosis. How we get to know? If it is less than 7.35, it is acidosis. If it is more than
Yes.
7.45, alkalosis. Is that clear? Yes or no?
Yes.
Right. So this is normal 7.35 to 7.45. PCO2, this is how I remember. 7.35, remove 7, 35 to 45. This is how I remember. So probably
No.
easier technique, right? Remove the 7.
Yes, sir.
So now PCO2 is easy, right? 35 to 45, same. All right. Oxygen is close to 100%, is so 75 to 100, no need to mug up. And HCO3, only things you need to remember, 22 to 26. And oxygen
Okay.
saturation, either pulse oximeter or ABG, it should be normally more than 95%. This is all normal. This is all normal. This is all normal value, right? What happens when the pH is less? It is acidosis. When pH is high, more high means 7.45, it is alkalosis. PCO2, when it is high, it is acidosis. When low, it
Yes.
is alkalosis, right? Oxygen saturation, partial pressure, right? It usually reduced in the asthma, right? We'll see it. And HCO3. So it is reverse. When CO2 increase, it is acidosis, right? When CO2 increase, it is acidosis,
Acidosis are
right?
released. Bicarbonate increases, it's alkalosis.
Sorry. Yes, tell me. When CO2 increase, it is acidosis. When HCO3 increase, it is acidosis, right? And this is alkalosis. And oxygen saturation is greater than 95%. Now apply this. Acute asthma, there are three category: mild, moderate, and severe. So we are talking about moderate and severe. So initially in asthma patient, when the moderate, they are going towards the severe asthma, pH is down, pH is low, means less than 7.35. In our scenario, 7.30. So it's correct. In severe asthma, you can see respiratory acidosis, pH is low, oxygen is low. In our scenario, it is less than 60. Yes, it is low, right? It should be 75 normal. It is less than 75 means low. It is right. Increase CO2. Normal CO2 is what? 35 to 45. Our is more than 60. It is high. And HCO3 is compensatory mechanism. It should be low, right? In our scenario, it is high. So it should not be high. It should not be high. In the scenario, it should not be high. 22 to 26, it is 32. It should be compensatory metabolic alkalosis. It should be low, but instead of low, it should be high. So here the answer is accept. Accept means HCO3. This is not present in severe asthma. You can see low CO2, you can see high CO2, you can respond with hydrocortisone in few hours. Your blood is pH is less than 7.35 because it is acidosis. So respiratory acidosis compensated by metabolic alkalosis. So HCO3 should be low, but it is high. So this is not the answer. So here the answer except HCO3. So once again, I think you go and read the metabolic acidosis ABG chapter. Probably once you are ready, we can discuss again more with ABG only in the next class. Let me tell you, right? But I want first you to read, right? Not the blank. So go and read once again the thing. So this is the answer, right? So HCO3 in moderate to severe cases of COPD slash asthma, patient become a member of 50-50 club. What do you mean by 50-50 club? The PCO2 is 50 and PaO2 is also 50, right? So they increase significantly. COT also increase and that is also, right? So this is what the thing is. These are the all normal values. So go and read once again. In asthma, there are hundreds of questions what they can ask you in the exam. One is ABG. So read ABG, arterial blood gas. We'll discuss next time in detail. Second thing is how you diagnose the asthma, how you differentiate mild, moderate, and severe. They will ask you, give you the scenario. Respiratory rate is 35, SpO2 is this, FVC by FEV1 is 50%, right? Tidal volume is this, blah, blah. So there are a lot of things, right? So you must know how you differentiate mild, moderate, and severe, right? You must know what is peak expiratory flow. You must know what is a pulmonary function test. You must know what is a methyl or acetylcholine test. Acetylcholine test. You must know this, right? And you must know the treatment of both acute asthma and you must know chronic non-severe. So if you don't know, go little bit basic and open up the chapter of asthma. They will not ask you only this, they can ask you this as well. Because I know they ask lots of questions with the asthma and related with the diagnosis, investigation, and treatment. So you must know this. This is one of the most high. This is third one. First one is a cervical cancer, pap smear and vaccine. Second is all trichomoniasis, salmonellosis, giardiasis, ascariasis. And this is the third questions in front of your screen. Let's move to the fourth question. A female patient presented with oligomenorrhea. She had 3 periods in a last year. She also had acne and hirsutism. Her body weight was 60 kg. Vaginal examination or per vaginal examination was normal. The diagnosis is polycystic ovarian disease, hyperprolactinemia, adrenal tumor, hypothyroidism, premature ovarian failure.
PCOS.
Polycystic ovarian disease.
Yes. Any comment?
So
So everyone is saying polycystic ovarian disease. Now the question from my side, can any one volunteer tell me what is polycystic ovarian disease and what is polycystic ovarian syndrome? What is the difference between these two? Polycystic ovarian disease, what you see in the USG, what you see, right? What is the cause of polycystic ovarian disease and what is the cause of polycystic ovarian syndrome? What is the sign and symptoms of both? How you gonna treat this both the patient? What is the complication of both the condition? One by one, head-to-head comparison. Recently asked question in exam. Polycystic ovarian disease versus polycystic ovarian syndrome. Anyone, open for all.
Mostly in disease, only the ovary part is involved with multiple cysts. And
Great. So in ovarian
in
cystic, the name itself suggests, right? Polycystic means there must be a poly means multiple, cystic means cyst within the ovary, right? So this could be a PCOD, right? And what is in PCOS?
endocrine abnormalities.
Insulin resistance and
Metabolic
risk of
disorder.
diabetes. Yes.
Metabolic
This
disorder
is a
and
metabolic disorder. This is endocrine disorder.
Endocrinitis.
Fine, fine. This is the biggest difference. Excellent. You can see plentiful of cyst, at least 10 cyst in one ovary, 10 cyst. Here the less cyst. This is another difference. What is the third difference? This is the two difference. What is the sign
Hirsutism,
symptoms? How do they present?
hirsutism is more common in PCOS because it's hormonal.
Okay, this could be a hormonal, so more common. And this is,
weight
could be
gain.
what? Fine. So answer for this is a classical PCOS, oligomenorrhea, 3 periods, acne, hirsutism, right? So this is PCOS, but I want you to understand and learn the PCOS versus PCOD as well, right? Our job is not just to mug up the answer, we need to understand the things. So what is a head-to-head comparison between this PCOD and S? So occurrence, first is occurrence, common in women worldwide. This is disease, D means disease, and S means syndrome. PCO is same, polycystic ovarian disease and syndrome. Definition, it's a metabolic disorder as we know due to hormonal imbalance. This is endocrine disorder of ovaries with immature follicle. So endocrine disorder of ovaries, right? Third thing is a presence of cyst, minimum number of cyst. As I told you, it is at least more than 10 cyst. So very less cyst here. Here the more than. This is how the name comes. Polycystic, multiple cyst, more than 10. Cause again is the genetic, right? Lifestyle, eating habits, mental health. It is again a genetic insulin resistance, the most important insulin resistance and weight. Metabolic. So when there is a metabolic syndrome, all you can see in metabolic syndrome, insulin resistance, weight gain, hypertension, diabetes, right? Dyslipidemia, this is all metabolic syndrome. Severity, PCOS cannot be reversed. This is extremely important. You cannot be reversed. It can be reversed. It can be reversed, right? So if you have some patient with PCO, you give the treatment, it can be reverted, right? But this PCOS cannot be. Treatment is most important, diet control, exercise, lifestyle, and medication here. Diet, exercise, medication, and surgery, right? And complication, hard to get pregnant, hard to get pregnant, easy to get pregnant with medical aids. So they can become fertile or pregnant. It is very, very difficult in such a patients to become pregnant, right? So these are the head-to-head comparison of polycystic ovarian disease versus polycystic ovarian syndrome. Is that clear to everyone? At least tell me yes or no.
Sir,
Hello.
symptoms will, sir,
Yes, sir.
will the symptoms will remain same in both?
Symptoms are remain the almost the same, sir, right? The incidence and prevalence of the PCOD is a very common than PCOS, right? So there are some genetic tests, as I mentioned, right? Genetics. Here the cause is genetics. So genetics may play a role to diagnose the exact things. But the simplest, when you do the sonography, right, and you get lots of cysts in the ovaries, or each ovaries at least more than 10, then it is more goes in favor of PCOD along with the sign and symptoms, right? So that's it. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes, sir.
Yes,
Yes,
sir.
sir. Yes.
Wonderful.
The
Next
diagnostic thing
questions.
will remain the ultrasound, I think.
Yeah, I mean, prima facie, it's ultrasound and history, obviously. Obesity and this all, insulin resistance and all. So primary would be, sir, this ultrasound. So you are called to the home of 48-year woman whose chief complaint is I am almost fainted when I got out of bed. She has been ill for 2 days with nausea, vomiting, and diarrhea. She had a temperature until morning when it's finally broke. She feels dizzy when she sits or stands up. Her skin is cool and calming. Her color is pale. Her pulse rate is 130 per minute. Blood pressure is 88 over 64 and her respiratory rate is 18 per minute. Pulse oximeter showing reading of 96% on room air. She has no other medical significant history. We did a chest ECG, right? Because she fainted. So we need to know cardiac or neurological. You find this ECG. What is the ECG? What the ECG looks like? Is it atrial tachycardia? It's a ventricular tachycardia. It's a
So
atrial
it's a ventricular
fibrillation.
tachycardia.
It's a sinus
Sinus,
tachycardia.
Sinus tachycardia,
This
sir.
is sinus
sinus
tachycardia,
Sinus
sir.
tachycardia.
tachycardia.
Sinus.
Okay, so somebody is also telling ventricular tachycardia. So tell me, doctor, how you differentiate ventricular tachycardia? What point favors in this ECG for ventricular tachycardia? It's a discussion, just learning point. Don't take it otherwise. It's not particularly targeting you, but this is how we learn together. Until and unless we apply and fully utilize our neurons, we will not learn. This
On
mock test
ECG, I
is
think,
about, yeah, so this ECG is showing what?
yes.
We have
On
four
ECG,
options.
wide
Narrow
QRS
complex.
complex, first of all, for VT, wide
Sir, it says
QRS
VT
complex,
Yes,
slow.
not
so what
narrow.
this
Here
ECG?
is narrow.
First of all, identify what this ECG is out of four. What is the problem here?
So
What
it's,
is the option?
Actually, the
Narrow
rhythm
complex
here,
tachycardia.
our interval is narrow.
So it's
That's all.
150 beats
All
per
the
minute.
there is no any other pathological
Lot
changes.
of answer. Sorry.
so
Fine.
simple.
So
It is a
let me
sinus
go through.
tachycardia ECG.
Yeah, let me show go through the chat because chat would be the best thing for me to these things. Yeah, because a lot of answers. Okay, sinus tachycardia. Most of the people are saying sinus tachycardia. Fine, fair enough. So what you see in the sinus tachycardia? Anyone else? Only one by one, only one. Why it is
Sir,
Sir,
sinus tachycardia?
the
P wave
rate,
is regular. P wave
the
is
heart,
present and see the RR
PQRS.
interval.
Yeah, go ahead.
first we check the rate of the heart, sir. If we check the rate of the heart, it is 300 divided by 2 block, so it is 150. So the rate is
Okay,
increased.
great.
Next we
So
go if it
300 by
is
2 is 150. So 130, 150 is heart rate. Okay,
yes,
fine. So this is tachycardia. You confirm it. Now,
yes.
which tachycardia it is? Atrial, ventricular, or sinus?
P wave
Because the
followed by QRS
ECG is
complex.
intact, because we can see P wave and QRS complex intact, so it means it's a sinus tachycardia. If we couldn't see the atrial contraction, we would go for the ventricular tachycardia.
Wonderful.
If we do
So,
P wave, then it would be.
yes, wonderful. So
Also,
basically,
the
this is
QRS is
sinus
narrow.
tachycardia. Yeah. So basically, you knows everything. I mean, just trying to make you understand. P, Q, R, S, T. So everything is here. P followed by Q, R, S, T. Then again P. So P followed by QRS, all regular interval, right? It's just the tachycardia. It's a regular PQRST complex, right? So it is a tachycardia, but it's sinus tachycardia, right? So answer here is sinus tachycardia. Another thing is she does not have any past medical history, no cardiac, no hypertension, no diabetes, right? Only just the hypotension. Why the hypotension? We need to find out each and everything because she has a vomiting.
Dehydration.
She has a diarrhea, so probably dehydration. So dehydration can increase the heart rate. Number one.
Mm.
She recently have a
Fever.
fever, right? Fever was also there, temperature was also there, so that also can increase the tachycardia, right? Heart rate increase, dehydration, and fever. Fever can also. These are the common things, right? When you get a fever, you have a tachycardia. When you have dehydration, you have a tachycardia. right? So this is classical case. See, oxygen respiratory rate is normal. So nothing wrong with the lung. If there is a pneumonia, if there is a bad infections or something else, the respiratory rate could have been increased, right? There is no apparently wrong in the lungs. So oxygen saturation is not normal, right? So oxygen saturation is also normal. So lung part is reasonably okay, right? There is no cardiac history, no past history. So we are not thinking of something bad cardiac. If this any patient with IHD, any patient with a coronary artery disease, always think of VTVF. Not in this scenario. In general, I'm giving you the tips in the exam, right? So when there is a, and this is sinus tachycardia. How the ventricular tachycardia, right? Just for your knowledge, P wave QRS. So QRS complex is a ventricular for your knowledge. Ventricular is QRS, right? So this is atrial depolarization, ventricular depolarization, PQRST. This is atrial repolarization, and ventricular repolarization is presented with a U wave, which is not seen. That is why we are not drawing, right? U wave. So there are atrial contraction, ventricular contraction, atrial relaxation, ventricular relaxation. So four stage. So P wave is always something wrong in the P wave means there is a atrial activity. Something wrong in QRS complex, it is a ventricular activity. And T is a ventricular, right? This is atrial depolarization, ventricular depolarization. This is ventricular repolarization. So something wrong in QRST, it's something wrong in the thing. So remember simple P atrial activity, QRS rather T ventricular, T wave inversion, T wave inversion, T wave inversion, ischemia, right? ST segment elevation, STEMI. So something wrong in the things, it is a ventricular, right? So PQRST, remember that. So something wrong in the P, it is atrial, QRST is a ventricular. So when there is a ventricular tachycardia means ventricular activity, no P wave. QRS, 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 QRS. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
There
Yes.
is no P wave like this. There is no P wave. Got it? No P wave in ventricular tachycardia. Whatever the artery is doing, ventricular keep on beating is QRS, 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 QRS. This is ventricular tachycardia. There are two categories. Monomorphic means morphology is same, right? Morphology is same. QRS, 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 QRS. This is monomorphic. Mono means same and morphic means morphology. So same morphology is monomorphic VT, and polymorphic QRS, then some irregular QRS, some irregular QRS. There is no A. Forget about A. Right? So this is polymorphic. Monomorphic, all QRS looks like a same. One QRS, this is QRS, same another QRS, same another QRS, same another QRS, monomorphic. Is that clear? Yes or no?
Yes.
Excellent.
Yes.
Yes, sir.
So think the basic things in mind, right? So nothing looks like here. You can see in each and every ECG, you see the P. Pick up any ECG complex, you see the P followed by QRS. Same distance, rate is this, regular, rate, rhythm. Only just rate is fast. That is why we call it as a tachycardia, right? Or arrhythmia. Less is Brady, high is tachy, right? So this is sinus tachycardia, classical case, right? Atrial fibrillation. Have you seen the sawtooth appearance? Yes or no? Atria. P wave only. P is
Yes,
this
sir.
is P, right? Then QRS, isn't it? Yes or no? At least tell me yes or no.
Yes.
Yes, sir.
So
Yes.
in atrial fibrillation, atria is like 200 times beating, right? Whatever the ventricle is doing is keep beating. So all P wave, 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 P wave. Sawtooth. Is that clear? Yes or no?
Yes. Yes.
Yes,
Yes.
sir.
Sir.
Right? Ventricular tachycardia, this is ventricular tachycardia. This is ventricular tachycardia. Right? Sinus tachycardia, this is sinus. So you need to know the basic things of the ECG, how the PQRST is generated. And this is again a nice example, sinus rhythm. This is sinus tachycardia. The difference is that the rate is fast. Otherwise, everything is same. And rate is low, it is a sinus bradycardia. So between two R wave, there is a you divide 1, 2, 3, 4, 5, 6. So 6 blocks, right? So this is how we count. 1 block, 2 block, 3 block, 4 block, 5 block, apparently 6 block. So 300 divided by 6 is 50. 50 heart rate is bradycardia. What is the normal? What is the normal? 60 to 90 is a normal. 1 block, 2 block, 3 block, 4 block. So 300 divided by 4 block is 75. 75 is a normal. Here 1 block and half block, hardly 2 block. Even I can count 2 block. It is heart rate is 150. 150 is more than 90, means it is a tachycardia. Less than 60 is a bradycardia. Is that clear? So we need to know the normal sinus rhythm. P is followed by Q, R, S, T. Again start P, Q, R, S, T. Again P, Q, R, S, T. Is that clear? Yes or no?
Yes, sir.
Right. So they may sometimes
Yes,
ask
sir.
you the such questions of tachycardia, right? So homework. First of all, do homework. I would be glad if you do the homework because I am doing so much of hard work for you guys, right? So I wish you have the same response to me, and this is for you only, not for me. So first of all, understand the normal ECG. What you cannot miss, ventricular tachycardia, you must know. Ventricular fibrillation, you must know by ECG. Supraventricular tachycardia, you must know. Atrial fibrillation and flutter. And first, second, third, Mobitz type 1 and Mobitz type 2. Oh, sorry, that is in second, right? First degree heart block, second degree heart block, third degree heart block. In third, first and second, there is no category. In second, there is Mobitz 1, Mobitz 2, and third degree. Is that clear? Yes or no? Yes or no?
Yes,
Yes,
sir.
sir.
Yes, sir.
Wonderful.
Yes, sir.
So if you don't know the ECGs of this, you don't need to be a. I don't want you to wall. What is a wall Parkinson White syndrome, right? I don't want this, right? Wolf, Parkinson, White, this all toxic. Usually don't come. These are the common things. VTVF is the most common, SVT is the most common. So you must know if they give you the picture of ECG, whatever the scenario is that you can, by seeing the ECG, you can answer this, right? If you are good in ECG, you just follow the basic thing. Forget about all options. This is sinus tachycardia. That's it. Why? Because you know the basic, right? So I'm not going much in detail of this now. For now, last couple of questions, let me finish. We have some supraventricular tachycardia. If you are interested, we'll take one cardiology lectures as well. But you first prepare. My main goal is you prepare. I don't want anyone to be blank in the class. You first little prepare. That helps you for the exam. Partner lost his wife by acute myocardial infarction and cardiac arrest 6 months ago. He present with loss of appetite, low mood, sense of guilt. What is the diagnosis? Bereavement, major depressive disorder or episode, anxiety disorder, bipolar disorder. It's a psychiatric question. Very common, easy question.
Mm.
Yes, post your answer in the chat box. Yes. Yeah, post. We are more than 35, 40 doctors. I got the answer only 3, 4. That's it. Yes, Lola, can you comment? What's your answer, Dr. Lola? Dr. Mohan, Dr. Nisha, Dr. Anjana, what's your answer?
Sir, major depression episode because it's been there for 6 months. Loss of
So what?
appetite, low mood, sense of guilt.
Okay, so what is the difference between bereavement and major depressive disorder? It is not anxiety disorder, so forget about. We exclude this anxiety. There is no anxiety. This is fact, right? Somebody died, so anxiety is gone. This is not bipolar. Bipolar means mania, hyper, and depression both. So it is not both extremities, manic depressive. So this is not a bipolar. How you differentiate head to head? bereavement versus major depressive disorder or episode. How do you differentiate head to head? I'm interested in head to head.
Sir,
There is
even
no
after
A or B
6 months
answer.
incident, he is having fever. Sorry.
Sorry?
Even after 6 months of the death, he is
More than
feeling
6 months.
low.
Yeah, so you give me some difference, na? I mean, how we differentiate bereavement from major depressive
The
episode or
cause,
disorder?
the cause of the this one is the bereavement normally occurs with the death of the near one or
Close one.
Yeah.
it's
Anyone?
associated.
Yes, Safa. Can you little bit speak little louder? Sorry, your voice is bit low. I can't hear you well. Yes, tell me now. Yeah, Aisha. Yes, tell me.
Sir, I feel this
A
is
bere-
major depression
Major depression. So, what is the
because it's
definition?
more
A
than
book
6 months,
definition of
feeling
major.
of worthlessness, guilt, persistent
Bereavement.
mood of low mood, decreased appetite, sleep. All this
O-
is
Okay, so those who have
Major.
given the answer A, just debate now. Let me tell you who has given the answer A as well, right? Dr. Susan Ilyas, Dr. Boni, Dr. MD Shadab Reza,
I think
right?
this is
For
bereavement
bereavement, there
because
is a cause is there.
One by one, one by one. We'll discuss. We are not in hurry. We'll discuss. This is learning platform. So don't hesitate to tell anything. There is no negative marking. Don't worry. Here we discuss, then we will not do mistake in exam. Discuss a lot here. Yes. A wala log batao. Those who have answered A, now discuss why it is not a
Sir,
major depressive
be-
disorder.
We see a cause
bereavement
over there.
is bereavement is something which has a reaction to a state of loss. So, like death of a spouse or divorce or something, and it's a period of sadness. So we take it till 12 months.
Okay. Bereavement will last till 12 months.
Yes, sir.
Great, wonderful. And major depressive disorder or major depressive
That
episode will last how
usually
long?
more than 12 months or greater
More
than.
than 2 months if it presents, no? Loss of appetite. They have the criteria, loss of appetite, loss of
Sir,
sleep.
So
yes, sir.
can
In
anyone tell me
depression,
what are the criteria of major depressive disorder?
major depressive disorder, sir, it's actually 2 weeks. It takes 2 weeks to diagnose. The striking difference is anhedonia, means absence of pleasure activity. The things which he was feeling pleasure before, now he doesn't like the sports or something. He doesn't like it anymore.
True, fine.
And
Anyone
there
else?
is there is a mnemonic known as side caps. So that helps in the diagnosis of major depressive disorder.
Okay. Anyone else wants to make any comment? So what I understood in a depression, SIGECAPS. This is acronym. Siege caps. S means here the S means sleep, right? Two types: reduced sleep, insomnia, or hypersomnia. I means interest. As she rightly told, interest, lack of interest in pleasurable activity, which is pleasurable activity like playing games, chit chat with friends, going to abroad, right? These are the pleasurable activity, right? So lack of interest in self and surrounding. Self. So himself, he has no interest. What going on in the surrounding is no interest. So this is lack of interest. G means feeling of guilt. This is all depression. E means energy. Energy level is low. Fatigue. Patient is very easily fatigued or loss of energy. C means concentration. Difficult making concentration. A appetite. P means psychomotor. Agitation, mainly agitation. And S means suicidal ideation, thoughts, blah blah. So this is what basically it's whenever you answer the depression, look at the sleep, interest, feeling of guilt, energy level, concentration, appetite, psychomotor, suicidal. This is classically component, right? Classical component of major depressive disorder. These are the major depressive disorder, right? So just keep in mind, this is excellent, this acronym for this, right? So let me show you the head-to-head comparison between this bereavement. So answer here is bereavement. So let's see, all right, what is bereavement? Character, features, duration, symptoms, and treatment. Between bereavement in major depressive disorder, bereavement features always associated with the death of a close relation. What is in the scenario? There is a death of the wife or death of the person, right? Cardiac arrest, death, acute my wife death. So this 1 point is favoring, number one. Number 2 point, right? This is 1 point favoring. Number here may not be associated with death. So depression is not death, it's a bereavement, right? Second, duration is 12 months. Depression is usually 2 weeks. Symptoms, preoccupied with the cause and circumstances of the death, feeling of worthless. And I already given you the long list, right? How you can diagnose major depressive disorder, right? And treatment is cognitive behavior therapy, or here you can give the treatment, right? SSRI, selective serotonin reuptake inhibitor, and ECT, especially for the suicidal ideation. Whenever there is a suicidal ideation, right? Suicidal ideation, you need to do the electroconvulsive therapy, ECT, right? That is electroconvulsive therapy. So this is the basic understanding, right? You can do little more research on this. And if some changes there, I would be happy to have your feedback. But this is all from the standard international books, right? So just go through it once again, take a picture of it, and we'll discuss more, right? So this is what all the thing is given here. And let me put a last question, so if you allow me. A 53-year-old male with past medical history of IgA deficiency and diverticulosis, present with a lower GI bleed, and is found to have acute blood loss anemia. Several minutes after starting a blood transfusion, he becomes agitated. On examination, fever, tachycardia, hypoxia, hypotension, wheezings on bilateral lung fields, and tongue swelling. What this hypersensitive it is? Is it type A, type 2, type 3, type 4? And those who give the answer, give me the answer. What is in A, what is in B, what is in C, what is in D? I want to understand all your concept about the hypersensitivity. So what is the diagnosis of this scenario? Forget about ABCD. What this patient is suffering from now.
Allergic reaction,
Now forget about this now.
anaphylactic,
Anaphylaxis.
anaphylaxis.
So this is anaphylaxis. Fine. So now let me give you the basic of anaphylaxis. There are several kind of shock. So this is looks like a anaphylactic shock. Anaphylaxis is different and anaphylactic shock is different. So shock comes in picture when systolic is less than 90 or hypotension. So they have mentioned hypotension. So this is looks like an anaphylactic shock. Apart from that, there is a hypovolemic shock, right? There is a cardiogenic shock. There is a septic shock, and there is a neurogenic shock, if I'm not wrong. Is that clear? Yes or no?
Yes,
So
sure.
all shock, we need to know the complete crystal clear picture of all the shock. So this gentleman was fine. What happens, right? He has acute blood loss, right? Probably because of GI, diverticulosis rupture, right? GI blood loss. He has given the blood transfusion, and after, so in anaphylactic shock, any patient of anaphylaxis, either there is a history of blood transfusion, and then same scenario comes, same things will come. Tachycardia, hypoxia, hypotension, wheeze. Tachycardia, hypoxia, hypotension, and wheeze after blood transfusion, after giving penicillin, same thing happen. After eating eggs, after eating spinach, after giving chemotherapy. So what is the bottom line in anaphylactic shock? There is some kind of exposure to some allergen. Exposure. Without exposure, anaphylaxis will not happen. Why it is not a hypovolemic shock? Why it is not a septic shock? It is not a hypovolemic shock because there is no hypovolemia, no diarrhea, vomiting, right? There is this hypotension is because of the some culprit, right? So what happens when there is a exposure? there is a profuse release of histamine, and this histamine can cause profound hypotension or vasodilatation, eventually vasodilatation and hypotension. This is a pathophysiology, right? So histamine, leukotrienes, right? They release from the cell called as a mast cell. Is that clear? Yes or no?
Yes, sir.
IgE mediated usually, right? So this is pathophysiology. So anything exposure after that you get this is anaphylactic shock, right? So can anyone tell me, if I want to treat this patient, how you gonna treat this patient? What is the treatment of this patient? 1, 2, 3, 4. This patient comes to the emergency room. In your emergency room, this patient comes. He was treated nearby hospital.
Adrenaline.
Right now, come to your hospital is a big hospital, tertiary quaternary center. Now, patient comes with these symptoms in your ER emergency room. How you gonna treat this patient?
First of all, stop the blood transfusion.
ABC
To stop the
protocol.
transfusion, then
No,
Obviously, I mean, you stop the blood
Duration.
transfusion. Obviously, culprit. So blood transfusion is stopped. Now, what is the first step? First step, second step.
adrenaline, duration.
Injection adrenaline.
Adrenaline.
Epinephrine.
Secure the airway.
Epinephrine right away.
Epinephrine and adrenaline. Just for your knowledge, epinephrine and adrenaline are the same thing, right? So epinephrine you tell it is same as adrenaline if you say adrenaline, but for people usually tell epinephrine. So we take it epinephrine. So now
Intramuscular.
epinephrine can be given to the patient. There are 4 questions.
Intramuscular.
I would like to ask you the 4 questions, not one question. So we diagnose that this patient has an anaphylactic shock. Anaphylactic shock. We did it. Wonderful. This is our diagnosis. Now treatment, right? Treatment, stop the culprit, whatever the drug, IV fluid, blood. Excellent. First is epinephrine. 4 question. Epinephrine, how to give? Number 1 is route of the injection.
I am
Right? Second
IM.
is the dose is of injection. Third is
for adult 1 milligram.
dilution, how you
10,000.
dilute it, given into the
10,000.
patient. Yes. Which route you give?
IM.
IM.
I am
Excellent. Another question. Site of the IM.
femoral,
Exam question.
Middle of the
medial
thigh.
femoral.
Anterolateral thigh. This is recommended. This is recommended. IM. Now tell me the dose.
1
1 ml,
milligram
2
at a
ml, 3 ml, 4 ml,
1
5 ml. How much?
1
1 ml.
1 ml.
1 is to
So
1000.
if I ask you, in case of anaphylactic shock, now you have a cardiogenic shock. Here also we should use in ACLS, BLS protocol or mainly ACLS, epinephrine. Isn't it? Yes or no?
Yes, sir.
All 4 questions for cardiogenic shock. What is the route of epinephrine?
I
What is the dose of epinephrine? What is the dilution of epinephrine?
we will give IV, sir, if there is a
IV.
cardiac arrest.
IV cardiac arrest. Okay. What is the dose or dilution?
1 is
1,000.
1 ml will dilute with 9
One
ml.
ml.
1
saline.
is 10,000.
Excellent. 1 is
10,000.
10,000. Excellent. Dose in milligram.
10
Uh,
milligram.
How much?
1 milligram every 1 to 3 minutes. Or every 3 to 5 minutes. Repeat it.
1 milligram every 2 to 3 minutes or 3 to 5 minutes, isn't it?
Yes.
So this all 3 change. I want you to, and here, I mean, just check it.
Must be
Dose by my
0,
sense. Here
0,
0.5
0.5
ml.
yeah.
Exactly. This is by my knowledge. Somebody told 1, but by
Yes.
my knowledge, it is 0.5 ml is equal to 0.5 milligram. Half milligram, here 1 milligram, right? This is absolute head-to-head comparison. You must know it. Is that clear? Yes or no? Yes or no?
Yes, sir.
Yes.
Yes or no?
Yes, sir.
Yes, sir.
Wonderful. So you
Yes.
should not confuse. You should not confuse between anaphylactic shock and cardiogenic shock. Drug is same, but the route is different. Dose is different, dilution is different. So I want you to give this take home message. That is why I discussed this little bit more. Now let's get back to the stem of the question. What type of hypersensitive it is? 1, 2, 3, 4, or none of the above?
Sir, it is type 2.
Okay, so someone is saying type 2. Okay, any other answer?
Anaphylaxis is type 1. No, sir.
Okay, so somebody is saying type 1. Fair enough. Somebody type 3, 4. We'll discuss. No? This is learning platform. That is what we want to learn here. No? We don't need to mug up.
So it's a type 1
Sir,
hypersensitivity.
sir, type 1 is because of drug induced, and blood reaction is in type 2. And type 3, I have a little bit confused. Type 4 is a delayed.
Okay, fair enough. So now I will go through the literature because I go through the official literature for each and everything. Then you tell me what type it is. After listening me, there are 4 type 1, 2, 3, 4. Right? So this 4 type, right? Here type 1 is IgE mediated. I told you already. IgE mediated means activation of the mast cell and basophil result in release of chemical mediator. I told you histamine and leukotrienes. Urticaria, angioedema, and anaphylaxis is the example of type 1. So this blood transfusion followed by anaphylaxis, what do you think what it could be?
So type 1.
Type 1. So answer for this is type 1. Listen all, you get more clarity. Type 2, what is type 2? IgG or IgM? No IgE. IgE is type 1. Cytotoxic reaction, IgG or IgM mediated. Antibody binding the cell with subsequent binding of complement and cell rupture. This is little different mechanism. Here, Ig directly bind with the mast cell. There is no mast cell here. Cytotoxic reactions. Cyto means cell and toxic means toxic to the cell. What happens? Antigen and antibody bind. Antibody is either IgG or IgM. Subsequently, they bind with the complement and cell rupture. So cell is ruptured. This is blood cell dyscrasia like hemolytic anemia, autoimmune thrombocytopenia. So this is type 2. Type 3 is again IgG. IgG is common here, no IgM, here no IgM. Immune complex formation, antigen antibody complex formation, usually with IgG or IgM, but mainly IgG, and deposition of this immune complex directly into the organ. That is, vasculitis is the one of the most important and commonest presentation. And type 4, as rightly someone said, T cell. This is all you can say in general. B cell. There are 2 lymphocyte, B lymphocyte, T lymphocyte. Type 4, T cell mediated or delayed hypersensitivity. Delayed. So delayed cell mediated hypersensitivity reactions. It is delayed is T cell. This is T cell mediated, can be further divided into blah blah. It's okay, fine. What is the example? Allergic contact dermatitis. It is a T cell mediated, delayed, not develop immediately like anaphylaxis. Steven-Jogren syndromes and other things are the example of type 4 hypersensitivity reaction. So that's all from my side. Here, stop the transfusion, manage ABC. Obviously, ABC is the first part of any emergency. IM, epinephrine, intra, antihistaminic, vasopressor, treat it. Type 1 hypersensitivity reaction that results from sudden systemic release of mediators such as histamine and tryptase, mast cell and basophil, IgA mediated, more common in IgA deficient patient. Our patient is IgA deficient. Our patient is IgA deficient. So more common in IgA deficient patient, right? So that's all from my side. Thank you very much all for listening me for almost 90 minutes. So thank you very much. Probably you enjoyed my MCQs and I would like to have a quick feedback on this session. So I would like to know more how we can improve more this learning platform more, or your suggestion, your feedback, your advice is highly appreciable. I'm trying my level best every time to make it more interactive. Comment
And
please.
we have 1, 2 more MCQs if you have time.
Actually, I'm going late for the hospital ICU, so if you don't mind, I mean, I spare 90 minutes, so probably next time we can do it, sir. One way
Thank
So,
you,
ticket
sir,
sir.
for me.
blood reaction will be in the type 2, I think,
Type
or
1, sir,
one.
I already mentioned you the clear-cut logic, explanation, and things. If you have some literature with you that this type of questions is goes into type 2, I would be glad to
I
change
got
it.
confusion,
Just
that's
give
why. You are
no
right.
problem. No, not me, right? Just give the authentic literature. You understand? That is why I'm not just giving the answer. I'm giving each and every point supported with some evidence, right? That is a learning. Otherwise, everything is in the book. Na? This is I did not presented something out of the blue. It's all in the book. But probably the way of my expertise and presentation will make you more understandable. If you read alone and if you read with me, probably it makes sense, isn't it?
Can you tell us a few examples like blood or medicines that will type 1 hypertension, type 1 hypersensitivity reaction, and type 2, what kind of patients we can suspect? Example, like we can say there's a type 2.
Yeah, this is what it is given here. Na? Examples are right. So type 1 is angioedema, right? Immediately once you give anything, urticaria, anaphylaxis is type 1. Type 2, blood cell dyscrasia, hemolytic anemia. Hemolytic anemia means like something if you hemolysis because of drug, because of some kind of antibody, either IgG and IgM attached with the red blood cell. You can say autoimmune hemolytic anemia, autoimmune thrombocytopenia, or ITP is the another name. So these all are the same. What it is happens in type 1, 2, 3, 4. It's in front of your screen. Great. Any comment? Any feedback?
Thank you so much, sir. This is really informative.
Excellent. Wonderful. Did you learn something new in this class or not?
Thank you, sir.
Yes, sir.
Definitely, sir. You
Sorry.
have cleared up the confusion of mine.
Wonderful. Anybody else? Yes,
Thank you very
Susan.
much,
Any
sir. It
comment?
was a very good class.
Yes, Dr. Mohan. I'm glad to have your feedback. Thank you. Yeah,
Sir,
we
one
are
of
doing
your
our
classes would be really useful, sir. Your class is really useful.
wonderful, Anna. So just push yourself a bit hard. I don't want anyone to fail. I want 100% result in our group. Yes, Bhavya. Any comment? And Susan, Elias. Yes, no comment. Fine. So let's pack up and thank you very much once again for your precious time on the Sunday. We'll catch up again with the next lecture, right? I'll keep you updated. Thank you very much. Thank you, Norman, for your feedback. Thank you.
Thank you, sir.
Take care. Bye
Thank you,
bye.
sir.
You
Thank you.
can get this on the YouTube channel by evening for your revision.
Thank you, sir.
Thank you very much.